Good morning and welcome to day 2 of the Physician-Focused Payment Model Technical Advisory Committee, known as PTAC. My name is Lauren Hardin and I'm one of the co-chairs of PTAC along with Angelo Sinopoli. Yesterday, CMS Deputy Administrator and CMMI Director, Dr. Liz Fowler, started our day with opening remarks on how our work fits into the Innovation Center's vision. We also had several excellent guest presenters share their ideas on opportunities to improve the development and implementation of performance measures for population-based total cost of care models to drive care transformation and improve outcomes and satisfaction. Today, we have a great lineup of experts participating in an exciting roundtable panel discussion, a listening session, and a panel discussion with CMS leadership. We've worked very hard to include a variety of perspectives throughout this 2-day public meeting, including the viewpoints of previous PTAC proposal submitters who addressed relevant issues in their proposed models. Later this afternoon, we will have a public comment period, and we welcome participants either in person or via telephone to share a comment. As a reminder, public comments will be limited to 3 minutes each. If you have not registered to give an oral public comment but would like to, please email ptacregistration@norc.org by 2:30 p.m. today. Again, that's ptacregistration@norc.org. Then, the committee will discuss our comments for the report to the Secretary of HHS that we will issue on developing and implementing models, performance measures for population-based total cost of care models. Because we might have some new folks online who weren't able to join yesterday, I'd like the committee members to please introduce themselves, share your name and your organization. If you'd like, you can tell us about the experience you may have with our topic, and I will cue each of you. So I'll start. I'm Lauren Hardin. I'm a nurse and Chief Integration Officer for HC2 Strategies. I've spent the better part of the last 20 years focused on complex and underserved populations, developing models and scaling them in multiple environments, as well as being part of the team that started the National Center for Complex Health and Social Needs. And I'll go next to Angelo.
Thank you, Laura. I'm Angelo Sinopoli. I'm a pulmonary critical care physician. I'm presently the Executive Vice President for Value-Based Care at Cone Health System in North Carolina. Spent most of my career working in large integrated delivery systems, building and managing clinically integrated networks and enablement companies to help improve their performance. And happy to be here today. I'll turn it over to Jennifer.
Good morning, I'm Jennifer Weiler, an emergency physician by training. Currently, I'm the Chief Quality Officer at UC Health Metro, one of the largest healthcare delivery organizations in Colorado, serving patients in the Rocky Mountain region. I'm also co-founder of UC Health's Care Innovation Center, where we partner with digital health companies to grow and scale their solutions that improve patient care and outcomes, and a tenured professor at the University of Colorado School of Medicine and former co-developer of an alternative payment model that was reviewed and endorsed by this committee.
Good morning. I'm Walter Leung, founder of Generation Clinical Partners. We are a medical practice based in St. Louis, dedicated to helping senior living organizations transition into the world of value-based care through more efficient medical care delivery models.
Good morning. My name is Jim Walton. I'm a general internist by training. Started my career in Waxahachie, Texas as a rural doc and transitioned into community health improvement, working for Baylor Healthcare System in Dallas, Texas, developing community health strategies for the system. Evolved to be the Chief Health Equity Officer, and then took over as a CEO of a large physician IPA in Dallas, creating an ACO that took risk for Medicare Advantage and Medicaid patients, and did that for about 10 years. Recently retired and now serve as a consultant.
Good morning. I'm Lindsay Botsford. I'm a family physician in Houston, Texas. In addition to serving as a PCP, I am a medical director with One Medical. We have practices across Texas. I also manage our practices in Houston that are focused on older adults on Medicare, where we take full risk and participate in the ACO REACH program. I've also been working in the quality space, certified in medical quality and quality improvement.
Good morning. I'm Dr. Larry Kaczynski. I'm a gastroenterologist by training. I spent my entire career in private practice in suburban Chicago, building a large GI practice there. For the last 10 years, I've been involved in value-based care, having founded a company named Sonar MD, which had its roots in Project Sonar, which was the first PTAC recommended physician-focused payment model recommended for testing. I also sit on the governing board of the American Gastroenterological Association and have been involved with oversight of guidelines and metrics committees. I'm in my third year on this PTAC committee.
Good morning. I'm Terry Lee Mills. I'm a family physician. I have a 25-year history of implementing and operating CMS pilot innovation projects over several states and several health systems. Long career in practice transformation, operational efficiency, quality improvement. Most recently, I've served as Chief Medical Officer of a regional provider-owned health plan, operating a total cost of care health plan system in the commercial exchange and Medicare Advantage space.
And is Josh or Chinny online, Amy? No, we want to acknowledge our other partners who are unable to join us today, Dr. Jay Feldstein, Dr. Chinny Polaru, and Dr. Josh Lau, who have all contributed significantly to this topic. And we want to thank them for their work in preparation of this meeting. So next, we're going to go to our first roundtable discussion, and I'm excited to welcome these experts for this panel who are going to share a stakeholder's perspective. It's really important to be hearing directly from our stakeholders at the point of care and really connected to implementation. And they will be talking about best practices for measuring spending and quality outcomes in total cost of care models. You can find their full biographies posted on the ASPE PTAC website along with their slides. And at this time, I'll ask our panelists to go ahead and turn on your video if you haven't already. And after all four panelists have been introduced, we'll have plenty of time to ask questions and engage in what we hope will be a very robust dialogue today. So presenting first, we have Dr. Danielle Whitacre, who is the Chief Medical Officer of Bloom Healthcare. Danielle, please go ahead.
Thank you. I'm deeply honored and grateful for the opportunity to address the committee today. My name is Danielle Whitacre, and I serve as the Chief Medical Officer of Bloom Healthcare. I have over a decade of experience as a family physician practicing home-based primary care. I began my career with rural medicine on the eastern plains of Holyoke, Colorado, where I provided comprehensive care in a primary care clinic, nursing home, and a critical access hospital. This experience instilled in me a profound understanding of the challenges in accessing care, a theme that resonates strongly in my work with homebound patients. For over 10 years, I have been part of Bloom Healthcare and its predecessor, Physician House Calls. Our focus is on delivering in-home primary care, and we take pride in operating our very own high-needs ACO. We employ our team of approximately 80 nurse practitioners, physician assistants, and physicians to bring primary care directly into our patients' homes. Our patient population spans across the metro region of Denver and the Front Range, encompassing 9 counties. Each of our patients faces significant challenges in leaving their homes, with some even relying on ambulance transport for mobility outside the home. The majority of our patients, averaging 87 years of age, require varying degrees of assistance with daily activities, from bathing and dressing to managing their finances. While many are elderly, some are younger individuals with disabilities who require in-home primary care to meet their needs. 70% of our patients reside in congregate care settings, including senior apartments and assisted living facilities, while the remaining 30% live in their private homes. Notably, we do not serve nursing facilities. Our overarching mission is to support these high needs individuals in aging in place, fully optimizing their function and well-being. Next slide, please. I'd like to talk about our key takeaways of our ACO experience, starting with what went well. The claims-based high needs ACO REACH quality metrics are precisely what we need. We are held to 3: rate of unplanned hospitalizations, all-cause 30-day readmissions, and my favorite metric, days at home. I cannot think of better metrics for high needs populations. They're simple, cause no burden to collect, and they are aligned with what our patients want. Another element that is right is concurrent risk score. Given the progressive and rapidly changing conditions within a high needs population, incorporating concurrent risk scoring within the measurement year is crucial. Claims alignment with quarterly voluntary alignment. High needs patients come to us in dire need of a practice designed to meet those needs. They need to be aligned to us quickly. Reasonable patient minimum for participation allows smaller practices like ours to participate in value-based arrangements. Primary care capitation and payment allows smaller businesses to have the funds to operate. Multiple risk options. Bloom opted for global risk, but not every practice is prepared to do that. Having another option allows more practices to embrace value-based care. Now, what needs improvement? We need expanded inclusion criteria. We touch roughly 10,000 patients each year. Less than half of those have straight Medicare. Only 1,400 align to our practice currently. We know that many of our patients who don't qualify for the high needs program should qualify. Benchmark predictability and stability. Regional benchmarks are more accurate and stable than historical benchmarks due to the ever-changing nature of a high needs population. We need a patient survey that is designed for high needs patients. We need faster access to data and attribution. We need expanded ability to voluntarily align in the home setting. The rules make it impossible for us to discuss programs like ACO REACH in the patient's home setting. A place where you would be allowed to would be a waiting room. We don't have one of those. So thank you. I look forward to our discussion.
Thank you so much, Danielle. We really appreciate you being here today. And next, I'd like to introduce Dr. Brian Smith, who's a family physician with Versailles Family Medicine. And also, Dr. Smith, I am a Kentucky resident as well. So really happy that you're here to join us today. Please go ahead.
I knew you were a Kentucky resident the moment you pronounced Versailles correctly. So
I'm glad you noticed.
So I've been in Versailles for about 20 years now, and started Versailles Family Medicine. I employ several nurse practitioners and physician assistants. We've been in an ACO pretty much since the beginning. Recently, we closed our ACO called QIP and then joined Evolent out of St. Louis, and we're also working with another ACO out of Florida on some other contracts. Versailles is kind of halfway between Lexington and Frankfurt. I was thinking we are a rural area if you're from New York City or Washington. We're a suburban area if you're from the Front Range of Colorado. And we do pretty much full scope family medicine, newborns to nursing homes. We don't do any obstetrics, but we do see lots of newborn kids, preemies. We work in 3 nursing homes, 2 assisted living facilities, and 2 memory care facilities. So we're pretty busy, and we also my home hospital, which is where I'm speaking to you from now, is a critical access hospital in Versailles. Next slide. There you go. So some of my frustrations, I guess I probably should have started out with positives, but I'm just going to go straight into my frustrations, are I feel like we spend more time, we have our population will have people coming and going from, California or Ohio or Michigan moving to our area, and then tracking down their reports on their last colonoscopy or their mammogram. That seems very challenging, and we spend a lot of time doing that as opposed to talking to our patients about why it's important to get it done or getting them scheduled for the next one. Another thing I don't quite understand is if CMS is paying for a mammogram or a colonoscopy or an eye exam, why do they not, or maybe they do know that they're done, why can't they tell us that they've been done and where they were done and when they were done? Similarly, vaccines, done in pharmacies, there's no consistent reporting for that, and CMS is paying for those vaccines. So here in Kentucky, we have Kentucky Health Information Exchange, and the vaccines are uploaded to that in an inconsistent fashion from pharmacies, it seems like. And then when we are trying to reconcile, if somebody got pneumonia vaccine and then tracking that down for our quality reports, that's can be challenging, and it should seem to me that that should be automatically known and be able to fed into us as opposed to us feeding it up to CMS. Similarly, like with a microalbumin being done at Quest or an A1C being done, my understanding is that those are reported and even the range is reported. So I don't know why all that information has to come from us as opposed to going from the lab to a national clearinghouse and then down to us if it's done outside of our office, I guess. So, and then one of the other things that's getting frustrating is the CPT2 codes, and there seems to be a variety of between Medicare, Medicaid, and Medicare replacement products. They seem to want to collect the data in different ways, and so we're having to import, or they would like us to report. Some people want us to do CPT2 codes, and some people want us to do ECQM reporting, and that not being consistent is burdensome. And then, the last statement I think is self-evidentiary. The things that we can control and like directly in our office, like whether a test was done or not, whether a patient was referred or not, that seems more fair to judge us and pay us by, as opposed to if the patient went and got something done or improved their A1C or lost weight or whatever. It's hard, I think, to judge clinicians based on those types of outcomes. That's all.
Thank you so much, Brian. And just for the committee to be aware, we will have time for you to ask questions after all 4 presentations are done. So please begin gathering these for the presenters. So next, we're excited to have Dr. Adrian Hernandez, who is the Executive Director of Duke Clinical Research Institute and Vice Dean at the Duke University School of Medicine. Please go ahead, Adrian.
All right. Thanks for having me here. So I'm a practicing cardiologist, actually grew up in Texas, so it's actually good to see some of the members where they're from and what they're doing. And I focus clinically in heart failure, and over the last nearly 25 years, I've often said As hard for it goes, so does America. And the reason I say that is that it's an example of a major chronic health condition that's a huge public health problem. There's been a lot of attention in terms of improving quality of care, especially as we have new evidence in terms of how to do so. And also it's important in terms of how we improve health, not only is around preventing mortality or preventing admissions to the hospital, but actually improving people's health status. Over the years, I've had the privilege of overseeing quality of care at the Duke Heart Center, as well as leading quality improvement initiatives across the U.S. In my current role, I have two perspectives, not only as a practicing cardiologist, but also overseeing a large clinical research institute where we work across the U.S. and actually around the world, especially around improving the health of people across different health conditions in different healthcare settings in the U.S. And also see this through the lens of what we do locally, meaning locally at Duke, Durham, as well as North Carolina. And often what we're challenged to do is that we're really trying to improve a person's day every day. And we're trying to do that every day, everywhere. And so if you think about where we're aiming to go for in terms of aligning our systems of incentives, how can we do so in a way that actually honors what we need to do for patients, which is when they come in and ask the question, will I be better off tomorrow, or will I have better days ahead? How can we answer that with clear direction in terms of where they are now and what we need to do to improve so that they actually have better days ahead? And so this graph actually highlights all the different places we get to work with, so-called looking under the hood and seeing what is easy, what is hard, and what do we need to do next. If you go to the next slide, I'll highlight some things that we've learned over the years, and there's certainly opportunities but challenges. We do spend a lot of time in research in terms of developing patient-reported health outcomes that are actually designed to actually understand the benefits or risk of a therapy, a medical product, or a strategy of care. Those patient-reported outcomes have been designed to ensure that they're valid measures, that they mean what they are intended to do, they're responsive to an action, and that action is clinically meaningful either from a patient perspective or a clinician perspective. There's also been increasing interest in using patient preferences for evidence generation. And so how do we do that also in healthcare delivery as people have different perspectives and actually may have different things that we need to do to improve their overall health and improve population health? And there's a ton of data in terms of that we generate for discovery for the understanding of benefit and these unmet needs in terms of what are the gaps in terms of patients' health status, and then how can we address those gaps in terms of both improving precision health, how we action on an individual patient, but collectively how we improve population health so everyone has so-called better days ahead. From a health system perspective, there are several challenges, and while the research world can often generate data that shows benefits or risk of different strategies of care or medical products, doing so in an integrated fashion of measuring and reporting and actioning on patient-reported outcomes to accelerate either prevention, diagnosis, and treatment can be a challenge administratively. There are literally thousands of patient-reported outcomes that one can choose. They may have different characteristics that may be operationally feasible or operationally valid in certain settings. But there are definitely some that can be clear prognostic measures, actionable measures, and actually guide us in terms of what may be needed to improve care. And this can also address both the benefits and safety and actually improve the overall patient experience and population health. And so it is the challenge of these diversity of measures and the complexity they have. But we're now like in an era where things can be done in a more digital way, doing things where we meet the patient before they come into clinic or to the hospital. Another real challenge is how do we get rewarded from a healthcare system, either publicly or financially? So we are considered, these incentives are aligned with adding the burden that may come with it so we can realize the total benefit. because it is true why these measures have been around for a while, many decades, in fact, they're rarely reimbursed or rewarded. And so I think the opportunity is for sure to address the needs through precision payment models, developing new treatment paradigms that essentially focus and incentivize better days at home or home time, and then also ensure that whenever we have a strategy of care or a use of medical products or improving quality of care, that we're facilitating the long-term game in terms of total benefits of healthy days at home. And then also ensuring we're closing inequities that may exist as well, doing so as well as underscoring what's valuable for population health. So appreciate the opportunity here and look forward to the discussion. Thank you.
Thank you so much, Adrian. I really appreciate your perspective. And next, we're excited to have Dr. Leung, who is the Senior Vice President and Chief Informatics Office of SCAN Health Plan. Please go ahead.
Good morning. Thank you for giving me the opportunity to participate in this discussion today. So my name is Leung. I'm the Chief Informatics Officer at SCAN. The team and I are providing the informatics function to support all business as well as quality improvement activity at SCAN. SCAN mission is to keep senior healthy and independent. So SCAN was founded by senior for senior in 1977. We originally in Southern California, but now expanded into 4 additional states. Right now, we are serving about 287,000 Medicare members and contracted with over 30,000 of the provider. So in the SCAN health plan size, we try to evolve the portfolio of the product to serve all different types of Medicare beneficiary. So from the traditional MAPD to special needs plan. And this year, we just launched the PACE program, as well as a program that's providing mobile care to the homeless senior. You can go to the next page. So in the first one, as I kind of mentioned about, like I have been involved in the value-based model, as well as incentive program, provide incentive program. Back to the days is I was in the commercial plan. So I believe there's a value-based model with sufficient incentive program to kind of incentivize the healthcare quality will have the best outcome in terms of like giving the flexibility for the provider to manage your care, as well as motivating them to improve the quality. So in terms of the success for the incentive program, it has to be transparent, and then the measures set need to be balanced to including all aspects of the care, ranging from some of the preventive service to patient experience, and then to the clinical outcome. So sometimes we want to incentivize the different kind of achievements, not just the performance. So we kind of developed the program to incentivize 3 aspects of the care. One is the performance, which is the meeting or existing a target level, or the improvement, which is incentivize the year-over-year improvements and the excellency. So we want to also awarding the best performer and recognize them. And then in terms of like the measure sets, I think we hear a lot from the provider that their patient is different, their patient is sicker. So we try to do as much as possible to have all the measure be case make adjusted. You can go to the next page. So some other measure that I want to kind of mention, I think we will discuss that in the following discussion, is we find it's like a true measure of the access to primary care and specialty care. Either this from the patient experience perspective, or actually using the claim or encounter data to measure those. have highly correlated with the lower utilization of the acute utilization, like the ER and hospitalization. So we really encouraging to include those kind of measure. We also kind of like start to measure something we call like access-related never event. Like for example, if the patient has the newly diagnosed with cancer, it shouldn't take like more than 14 days to get an appointment for the oncology. So we want to kind of measure that. Just want to kind of what the provider partner who can provide those service right away. In terms of the health equity, both CMS and us, we want to promote the health equity. One thing is the health equity is not just the income or the disability. So in our own study, we found this is highly correlation between the pair of the patient and the provider language and the outcome. If the provider and the patient speak the same language, the outcome both on the utilization and the quality measure are better. But on the other hand, if they're not speaking the same language, the outcome are worse. And you can go to the next page. Oh, okay. So yeah, I think it's like the other kind of side is the mental health care also. So we also look at the mental health care measure, and they are also highly correlated with the utilization. So by controlling mental health care, it also helps on the medical utilization also. That's it.
Thank you so much, Moon. All of these presentations were very interesting, and I'm really excited to have the diversity of perspectives here with people at the point of care actually implementing this, as well as looking at this from a research and design standpoint across multiple settings. So at this time, we're going to ask some questions, and committee members, if you have a question, please tip your name tent up, and we'll go through each presenter giving a response to the questions. Just for the sake of time, if you can keep your responses to a few minutes, we do really want to hear the depth of your understanding though. So please feel free to also play off each other if you hear something interesting in what one of the other presenters has said. So I'm going to start off with one question to get everybody going. So are there gaps that exist between what is currently being measured and the types of performance measures that would be most meaningful for providers and patients and caregivers? And what are those gaps? And we'll start with Adrian.
Yeah, so I'll say that there are kind of two kind of big buckets here. So if you consider a patient's perspective, one of the things that they often comment about is time at home. And so we're not necessarily focused on that. And yet that's something can be measurable, it can be actionable, and also can have at least some idea in terms of what we're doing as a healthcare system in terms of providing best supportive services that actually may be better for transitioning patients from hospital to home, and also ensuring that they have healthy days at home. The other thing is more specific for certain conditions, and I'll use heart failure as an example. There's a wealth of data in terms of health status measures, such as the Kansas City cardiomyopathy questionnaire. It's prognostically important. It's meaningful for a patient's perspective as well as clinicians. It's actionable. It's actually feasible in the research setting. Yet in the healthcare setting, it may be more administratively complex. But as things are evolving, where we're actually engaging with patients before they come into clinics, asking them information such as their insurance, we should also be able to tailor our engagement to ask more information that would guide their visit experience and help us focus on what their clinical needs are. In certain domains, and there are multiple across many different chronic health conditions, where there are patient-reported outcomes and health status measures that can pass the test and be easily implemented, and we should do so.
And Adrian, can you speak a little bit more? You mentioned engaging patients before they come into clinics. How is that being done best on a national level?
Yeah, well, I'd say it's highly variable. So, but and it goes in waves. And so, as people have concerns about, say, mental health, then that's say, for example, a common measure that was actually engaging patients before they came in to see if they had any mental health concerns, or using structured measures such as a PHQ-9. And so that's an example that could be done that helps guide us in terms of what we may have missed or what someone may not necessarily be comfortable saying in clinic, and we should be able to integrate that. And then there's some examples where in disease-specific areas for which we're getting information before they come into clinic to help guide us in terms of what's most important for the patient and their family.
Thank you so much. Let's go next to Danielle.
Yes, thank you. There are definitely, my patients would say there are definitely areas of opportunity. I really hesitate to create more things to measure, to try to address things like gaps in care. I said in my introduction, the high needs ACO metrics that we're held to really encompass, the things that matter to patients and looking at the individual patient and figuring out how to keep them how to increase their days at home, how to avoid hospitalizations and unnecessary send outs to the emergency room. We need the flexibility to be able to decide what means we take with our patients to get that done. So yes, when we look at when we ask our patients if there are gaps in care, they definitely will have areas of opportunity they'd like us to look at during transitions, having healthcare professionals collaborate more between different settings. But looking at things to measure to improve that really really makes it difficult and burdensome on providers.
It's very helpful. Moon, what would you say?
Yeah, I was saying it's the mental health type of measure, like Dr. Hernandez kind of mentioned about, like, for example, we start to measure whether the provider doing the PHQ-9 prior to having the visit, as well as the provider have the follow-up visit when the member have the mental health related admission. So the other thing is, I like what Dr. Hernandez kind of mentioned about like health status, but one of the challenges when we kind of measure that, the performance measure in our setting is because there's a lot of patients is not kind of necessarily coming to the health plan, or may not even coming to the office all the time. So we all rely on sending them the survey or calling them to fill out the questionnaire. So sometimes the non-response biases could be creating issue when we kind of tie this to the performance kind of measure. So I would like to kind of hear like what others thought about, like what the other thing can reduce that bias.
It's great. Thank you. And Brian, how would you answer? You are muted right now.
You had unmuted me before and muted me back, but all right. I think the clinical measures are pretty robust that we currently are required to report. I can't find any, gap there. I mean, I think it's a little frustrating. You've got a 85-year-old and their blood pressure is 142/92, and that's out of range. But then I try to give them an additional blood pressure medicine, and then they're in the ER for a syncopal event. So like as opposed to like the blood pressure at the last office visit, maybe average of the year, or the guidelines, I think, for older people, and I'm sure Dr. Hernandez knows better than I do, is it's a little bit loosier-goosier for systolic and diastolic blood pressure control. And so that can be a little bit frustrating from a clinical gap standpoint. From a patient-oriented standpoint, we have students, and what I tell them is patients come in to an appointment with an agenda, and I come into an appointment with an agenda, and my agenda very rarely matches that patient's agenda. I want them to get a mammogram and a colonoscopy and their lung cancer screening done and lose weight and take their medicines appropriately or just fill their medicines. And they're coming in and, somebody in their family just died and they want, something to help them sleep and get through this tough part in their life. But then, and their blood pressure's up because they're stressed out. And so what am I supposed to do? So I think an interesting patient measure would be, not doctor-patient communication necessarily, and did I explain what each medicine was for and why I'm ordering a colonoscopy, but, something more general, like were your goals of care met? Like the reason why you came to this appointment, was that were you satisfied with the outcome of the appointment? And then I think to address something Moon had mentioned, I think, if there's a way to get us to, and I don't mean us, I mean you, because I got enough to do, but a way to get the patient the survey like on their way out the door almost, instead of, a week later or a couple weeks later. If it's, you see all these advertisements these days about text communications, and, I'm sure that's not HIPAA compliant and stuff. But I would imagine there's a way to do that, where you're getting that, you're getting an answer closer to the time of incident, as opposed to, I don't even remember what I did last week, and let alone what I did at the doctor's appointment last week.
It's really key points. So I want to put that out to the group. So Adrian and the rest of the group, are you seeing any best practices in getting that real-time patient-reported outcome or perspective data that you would share?
Yeah, so and that's also relevant to Moon's comments. So, we do have to make things super easy for patients or caregivers to report into, because otherwise, for patient-reported outcomes, otherwise there will be a bias sample, and so that wouldn't give the perspective that we would want. The second thing, actually, we need to close the loop in terms of do something with it. So where I've seen best practices is actually it's integrating into someone's practice. Patients understand, like, hey, we really care about X, and let's just say heart failure, to help us follow this, ensure that we're doing, helping you over the next 6 months. Periodically, we're going to ask you about this, and this will help us understand how you're doing. How's your journey? Are we going in the right direction? And so at least they know that, hey, if I do this, actually, there's going to be something that I report back that will be helpful here. And maybe there's even a carrot, because if you're doing really well, we may not actually make you come in, because not coming in isn't necessarily always a benefit, having to deal with traffic or parking. But if you're not doing well, then we want to contact you to see how we can get you better. And so that at least, make sure that patients understand these, say, health status measures are meaningful. There are going to be action. And it's not just something that we're reporting into the government or our corporate offices or a payer, that this is going to be something meaningful. Same thing happens in cancer for certain areas, as well as mental health, as noted earlier.
Yeah, one thing I want. Oh, go ahead. Sorry.
Oh,
Go ahead, Danielle.
Yeah, I was going to ask Dr. Hernandez, has there been work with determining how best to obtain patient feedback in high needs populations? I really worry that the standards CAP survey It's 60 questions. With a high needs population where 65% have cognitive impairment, it's not meaningful. And our CAP surveys the response rate is so low. We haven't been able to figure out how to use it for anything. It has not been meaningful for our practice.
Yeah, and I think that's where, like, the idea that, like, we have to have these things tailored. There's, unfortunately, as everyone knows here, one size does not fit all. And so we have to meet people where they're at. Also consider how we're engaging others that are around the patient in terms of proxies or caregivers. And then also, like, for those who aren't able to say, do something, for example, digitally, how do we do something that's, for them in the waiting room or for them by telehealth? And so, we got to do things in a way that's going to meet the person where they're at. And also, I think for the other point is the burden, like, I have a visceral reaction to anything that's 60 questions. And so, and there are ways for us to think about easy measures that people can do, visual analog scales. It's not perfect, but does it give you directionality here? And on average, are we doing something better? Have we made sure that that person's experience and their health is doing better, going the right way?
And I think to Dr. Smith's point, I mean, sometimes our agendas are different. And so what you want at the end of the day is, to me, something like a net promoter score. Like, would you recommend your provider to somebody else? And I don't know, that might be too loose for value, but I think it does give us some information. Right now, I get nothing from the patient experience survey, unfortunately, but I have a different population than most.
So there's a couple of things, like Danielle, I think what we're trying to do, we're trying to shorten the survey. Instead of a 60 question, we're trying to make it like a short survey, depending on what we want to measure at a time. So we kind of quarterly set it out so we can measure the thing consistently. So I want to also comment on some of the things that Dr. Smith kind of mentioned about, in terms of the patient, what's matter for the patient. I think there's some age friendly system measurement NCQA is developing. It's going to help, because we're also seeing some provider, they implement it they call it My Story. So every single patient they have, they asking them what is their story, because it's mentioned that different people, the motivation is different. Some patient is the motivation is going to the daughter wedding so they can improve their health. Some people is going to the travel, so the motivation is different. So I think this one of those type of measure, like the age friendly type of measure, is good. The other thing I want to mention is I know texting is not HIPAA compliant, but I've seen some of the provider using some HIPAA compliant app that the patient installed in the mobile phone. They can get those quickly respond after the visit, as well as the provider can do a follow up with the patient using the app, which is HIPAA compliant. So more and more of those available. I think we should look at that.
Really helpful. Go ahead.
Throw one other thing. And this has to do with technology, I guess, and rural and underserved. We have a lot of patients with either poor internet or no internet connection or a flip phone. And right now they're being punished, because I'm being punished via telehealth with reduced reimbursement if I can't do a video chat with them and not just a phone call chat. And, that's the opposite of equity, I would say. And so that, from a technology, just because we're on the technology standpoint there, I think I wanted to throw that in.
It's really helpful. We're very interested as well in hearing very specifically about the challenges in rural related to measures and the policy opportunity there. Danielle, did you want to add anything related to your access?
I'm sorry, my internet had a pause. I didn't hear the question.
We're very interested in the rural perspective about barriers and also policy opportunities related to that. And when Brian was speaking about the telehealth and like the broadband access issues, wondering how that's impacting your intersection with clients and recommendations.
Yeah, home-based primary care has a population where telehealth isn't a possibility, not because there isn't access to internet in metropolitan areas, there is, but because our patients are cognitively impaired and they can't use a smartphone or a smart device. We have created some workflows to assist in that in cases where we have an on-demand service. So we're deploying staff that essentially act as a telepresenter for to connect with a provider who's sitting at their home, so that the staff can be deployed in different regions to be able to access that. So, but that there's technology issues, but there's also cognitive impairment that you have to keep in mind, and the fact that a lot of our patients just aren't able to use those technologies.
Very helpful. I'll go to another question, and actually I'll go to Jen next.
Thank you so much for being with us today. I've already learned so much. I actually have two questions. My first question is, I think, focused at Drs. Whitacre and Smith. I'm curious, how much of your total practice costs are dedicated to data collection, meaning getting information to make clinical decisions? So we've heard a little bit about the challenges related to manually collecting information that's outside of the practice, person to person, verbal collection of data. So that's my first question. What would you estimate is the total cost to your practice for that?
Significant. I mean, I think the trick there, you said to make clinical decisions, and I think that the problem is if I have a gap in data that the patient I know had a CT done 2 months ago at a different hospital, and they think it showed something that needed to be repeated, but they're not sure what, then to make that, then I'm going to just order another CT. So it's going to increase the cost as opposed to, me having one of my staff track it down. I employ 3 people in case management. I have a staff of 26, and one of their chief things is to retrieve records from outside hospitals that I'm not integrated with or other doctors' offices, so that I have that information on hand. So it's it's at least outside of provider expense time, I would say it's at least 10% of my employees spend time collecting information, or spend 10% of their time collecting information, whether that be one employee, 2 employees out of 20 doing it full time, or 20 employees doing it 10% of their time.
Yeah, and I think with a high needs population, with metrics that are absolutely claims based, I don't have the burden for my performance metrics. That being said, there's opportunity that I think we could utilize more resources, but I think for many small practices, you're not going to. We're missing an opportunity to take a look at some of the data that's given to us through the ACO REACH program. We do get claims data. The data that we get, it takes a data analyst to even know what you're looking at. And so we have we've been in a part of this value-based program for a few years now. And so we've finally figured out with the data analyst how to look at the data. But there's definitely insights we could be getting, but aren't currently because we don't have the staffing and the resources to really crunch these numbers. I know there are vendors out there, but we've talked to people that have quoted us at over $100,000 a year to crunch numbers. It's just not feasible. And I think that if you're looking at a value-based model and you're providing your participants with claims-based data, make it understandable. I mean, it seems like instead of having each individual practice hire vendors or hire their own staff to crunch numbers to find valuable insights into utilization, seems a little backward. It seems like there could be a way to present it in a way that's more usable. I'll stop there.
Yeah, thank you. That actually tees up into my second question. So again, I think I'm going to start with Drs. Whitacre and Smith. First of all, again, I just want to acknowledge, thank you so much for what you do. This committee had a chance to focus just on rural care at one of our last meetings. And not only are you looking at vulnerable patients, you're in resource poor environments, and you're choosing to participate in programs that take on full risk. It's really this trifecta that I think you all have a really important special voice to share about not only what you're doing and why you chose to do it. So that leads into my question. And the reason I asked the first question was really around they're not hidden costs, they're actual practice costs that are important to delivering high quality care, which is the focus of our discussion today, but they're more indirect costs as opposed potentially to direct costs. And you're quoting double-digit % of your total spend dedicated to doing this important work. So my question for you all is, this committee thinks about incentives, financial incentives. Can you talk to us about where are there opportunities to improve what you're doing through incentives? What would those look like? What would make your practice better from a financial incentive perspective? Or what would incent your colleagues to do more of what you're doing?
I had a radical solution years ago, and it'll never happen, but it was to you pay the specialists when they send us their consult note, and that's when they get their payment. And I think we get 100% of our consult notes in that case. Same could be extended to hospital discharge summaries and H&Ps and imaging done in hospitals. Right now, I see all of of course, I'm a primary care physician, so I don't know what outreaches CMS is doing to specialists and to hospitals to force them or encourage them to cooperate and send us more data. And it's, and then sometimes it's, when it does get turned on, it's, I'm getting, glucose measurements 4 times a day on an inpatient and at a neighboring hospital that happens to be a patient of mine, but I don't get their discharge summary. And so I think the incentive has to come at them. I feel like, we're doing as much as we can. And I think, what the problem is, it leads to, I think, patients, well, I went to X, Y, and Z hospital, so I'm going to follow up with a doctor that works for that X, Y, and Z hospital because they're going to have an integrated health record with what happened in that hospitalization. But I think hospitals lose track of I don't know the exact statistics, but I think it's, we provide 75% of the care and they spend 75% of the money, or, something along those lines. And that's, so I think it has to come from y'all directed towards the specialists and the hospitals.
I agree with what you're saying, Dr. Smith, and transitions of care are particularly problematic. And I think you highlighted some of the drop balls between those transitions. I think with the ACO REACH program, we do have the ability to create benefit enhancements. And I think it's an area of opportunity that we've started to explore, but it's really hard to figure out the incentives for our preferred providers without the data to back it up. And so we get our performance data, but it's totally aggregated. And so I don't have specific patient level data to know like which of my, SNFs are doing a better job. So I think there are opportunities within the ACO REACH program now to allow us ability to incentivize those that we're working with that are taking care of our patients well, and incentivize for the good work, the good transitions of care, better outcomes with home health and shorter lengths of stay in the hospital, whatnot. There are opportunities, but without the data to be able to pinpoint what teams and outside entities are doing a good job for us, it hamstrings us to create and design incentive programs for those partners that'll make sense and that they'll buy into and be able to do the work.
It's really helpful. Walter.
I wanted to add my thanks to our panelists for just a really informative discussion. I have two questions actually. One for Danielle about her practice specifically, and then the second one more for the broader panel. So Dr. Whitacre, you mentioned maybe 12 to 15% of your 10,000 patients in Leung are part of the high needs ACO. My question is, are the remaining 85-ish% of your patients in the value-based program, and if not, do you feel like they receive kind of different care than those in the high needs ACO?
Yeah, I'm really glad you asked me that. I can say because of the ACO, we've been able to create, even though we have 1,400 in our ACO currently, our census is about 6,500 at any given time right now. All of our patients are receiving the benefit of that interdisciplinary care team. So even, we don't, currently we're able to do that. We don't discriminate because of the payer. So, we've got a really robust team of social workers, nurse care managers, pharmacists, that are supporting our providers out in the field and helping with transitions of care, helping collaborate with our home health organizations and SNFs that are taking care of our patients. And that wouldn't be possible without ACO REACH. In effect, though, the other payers that we're working with are benefiting from ACO REACH. So I want to emphasize that that many people are benefiting. Many of our patients are benefiting from ACO REACH, even when they're not in the program. Not to say that that's right, but it's the reality.
Thank you for that. And actually, the second question is both for you and the rest of the panel. So we've heard a lot about the importance of the interdisciplinary team. You just mentioned it as well, how important that is for your population. We've heard it from different panelists in this session and in prior sessions. And yesterday, one of our experts mentioned the importance of a balanced portfolio of performance measurements in value-based programs that includes measurement of care integration or care provided by the interdisciplinary team. And my question is, do you have a good way of measuring that? How do you measure interdisciplinary team care that's effective?
I'll chime in and say, I think that's a really hard concept to measure directly, and for a couple of reasons. One, for different areas, it may be more difficult in terms of access to different team members. Second thing is that how teams are formed also may be different depending on the health condition or health area. And then the third thing is that there may be, I'll just say, different successful models are tailored to different communities. And so it has a variety of challenges, even if we've demonstrated that that type of practice or healthcare model is highly successful. It poses a host of challenges, in my view, but is highly valuable. So that's a real conundrum. Look forward to the magic answers that others may have.
A proxy for it could be CCM billing. I don't know if everybody even does that, though. But that's how I fund my interdisciplinary team, and is through the billing that we're allowed to do now for CCM. But I agree, it's imprecise to say the least. But that would be the only way I could think of that's already being done to measure that.
I think an indirect way, I think within our practice, for example, we impanel our patients to teams. So we know that, we've got multiple interdisciplinary care teams. So if we had patient level data that we could, because we impanel, we know which teams are doing things better than their peers. And so we could pinpoint top performing providers, top performing teams. And in doing so, we might be able to find successful strategies that those teams are employing and maybe attempt to replicate that. It also could help us determine areas of necessary improvement as well if we see a team not as effective as another team. So I think there are ways within our practice anyway that if we had the data to back it up. And currently, like I had mentioned, the barrier is the fact that our performance level data is aggregated, and it's also almost a year. It's a year-long lag, so it's really hard for us to do anything meaningful with that data. That being said, there are leading metrics that we're utilizing. So a lot of opportunity through the ACO REACH program to utilize data that is unrealized at this time. But our practice has really dug into risk stratification and finding within our population metrics that would help determine where to deploy our resources. And we're utilizing our internal data. We've designed a way to integrate with but get data from our health information exchange, and know how many times our patients are hitting the ER in the hospital, And so we've got dashboards that kind of alert us to certain data points that can help us decide where to deploy our resources. And there again, our patients are seen in the home, and we go to see them proactively. So it's a different practice model that I think is really, really a benefit to high needs patients.
And Moon, did you want to comment as well?
Yeah, I don't have much to comment, but I think it's our kind of mostly using the claim or encounter database to analyzing the data. So it's rely on the provider to code those. One comment I have is about the health information exchange. It sounds like it could be variable to the provider if it's easy to access to it, and then the cost for access to the health information exchange. It kind of, because from our experience it's not cheap to get access to it. So I think will be helpful to kind of reduce that, make it easier for the provider to get access.
Thank you so much. Jim, you had your tent up. You're good? All right. Larry.
Well, you all seem like you're in the trenches trying to do your very best, and I'm impressed with the concept of days at home, something I probably haven't given enough thought to. That's a great measure. But how do we know what's going on during those days at home? And so something this committee has worked very hard with last year in crafting models for specialty care was the concept of high-touch proactive care. And so I guess my question is, and I've heard the word proactive from Dr. Whitacre just a few minutes ago, all this reactive access to data is great. And what the patient feels like after their visit is very important. But what are we doing to avoid problems? What are you doing out there proactively? Are there use of wearables, use of digital devices in the home, blood pressure monitors, even scales? Are we doing anything to know what's happening during those days at home?
I can comment.
I can speak to that a little bit, Dr. Kaczynski. In our high needs population, we are definitely proactive. I think it's simpler though even than wearables, and I think our patient population aren't. We tried that. We tried doing some in-home patient monitoring and didn't find it clinically valuable for our patient population. I think there are certainly populations where it could be, but I think it's really simple in that getting in front of patients, building relationships, and understanding what matters most to them. The 5 M's we talk about in geriatrics, but really making sure that we are proactively managing and actively in there, finding opportunities that our patients don't raise their hand and tell us about. Optimizing that med list, finding areas of opportunity to improve their function and in the home, improve symptom management that, again, our patients, they think they're old, they don't know to raise their hand and figure out, have their providers work together and figure out how to make things better, how to improve quality of life. So I think, it's got to be high touch. And unfortunately, I don't see in our population, we haven't seen the value be realized for things like, the wearables and the home patient monitoring.
I guess 2 comments I have on this is that just because there's an app out there for it doesn't necessarily make it useful. So it's along Danielle's comment says that there can be situations where data overload isn't necessarily useful. It's not actionable. Like, how do you know, like, if someone had something that was different today versus yesterday? And so that's the challenge, for example, for wearables. The second thing is that to integrate with a person's life, I often find that the best kind of remote monitoring or integration of those types of data is the passive collection, where there are alerts that are integrated in terms of triggering when someone is doing poorly, and that can be actionable. Now, how that would get integrated in terms of the context here of physician practice measurement or healthcare system measurement, that's really complicated, and at least I would favor doing things that are simpler and combine a lot of different things and allow different practices, for instance, to tailor how they would actually so-called improve the home experience or the home time.
And Brian, you're muted.
I think you run into the paradox of people that need that kind of monitoring the most, or in my practice at least, are the people least able to use the technology successfully, and push the button at the appropriate time or not push the button at the appropriate time, or weigh themselves before breakfast or after breakfast. That kind of thing is that's what makes home monitoring tough for me. We did have a success with it with heart failure patients, but they're stable for a month, then they remove the monitoring equipment, and then you're like, what do I do now? And then that becomes it doesn't seem to be a permanent solution because nobody pays for it, for the rest of their life or whatever.
I think you just said the magic word. Nobody pays for it.
Let me go next to Lindsay.
Maybe that's good. Dr. Kaczynski and I are on the same page here. So I guess maybe for Dr. Hernandez, I think we've heard arguments and good rationale for why there's opportunity in the space of patient-reported measures. How does it get paid for? As we think about the move towards total cost of care, is that something that is baked into, that we're going to need to think about baking into these total cost of care models, that this needs to be part of it? Is it paid for through other ways? And how can we reduce the cost associated with it?
Yeah, so I think that's one of the big challenges, is that despite these measures being around literally for decades, in some cases, how they translate into healthcare delivery does require financial alignment. And so if that is incorporated in terms of the total cost of care, again, for certain measures that are valuable, actionable, and we know data that supports that they will improve the health and well-being of someone, then that could be integrated in terms of a value-based care model. The health systems will certainly align with that here. I think that one of the key challenges here is that do you address it in more general ways across large populations, or are they focused in high priority populations for which we want to really improve the health and well-being of for outcomes for patient populations that have a high burden of disease and expenses here. And so I think that's, why I use heart failure as a good example, that can align in terms of a very valid measure. It can be incorporated and relatively easily done in care delivery. It can be actionable, and there are other areas like that. But it can't be for everything for everyone. And as noted, part of the discussion here, unfortunately, many patients don't just carry one single disease. And so the complexity of comorbidity or other health problems have to be considered, as well as the other surrounding factors that may be difficult for improving their health. So, but it can be done. I think we can find areas where it should be done.
So we are also very interested in equity and health-related social needs. So I wanted to put out to the panel, Moon, you mentioned the impact of language and how important that was in the population. What measures are you finding meaningful related to equity and health-related social needs? And what recommendations would you have for the committee in looking at that as part of performance in total cost of care models? We'll start with Moon.
Yeah, and first and foremost, we're trying to kind of like collect the data. I think like the member, what language they speak, as well as the race. The good thing is CMS provide some information about the race. It's also helping us is to getting some other information about where they live, and then the social vulnerability kind of index going to help us to risk stratify the member. So in terms of the measure, we try to like incrementally improve the closing the health equity by looking at, like, for example, we see that the African American member have much lower kind of like a full shot rate. So we kind of deploy and incentivize the provider to get this rate up. So we have seen this like increase it by 50% in a year by doing so. And also like for some of those measures, like controlling the blood sugar as well as medication adherence on statin measure and hypertension kind of medication is much lower for Hispanic population. Part of that is could be the culture, part of that could be a language barrier. And we kind of like trying to deploy like the culture equivalence, kind of like a staff to talking to them, trying to understand why they're not on medication, is any kind of barrier. And we've seen this like improvement, like a few percentage point improvement, which is big for medication adherence, as well as the hemoglobin A1C control. So we're trying to be focused on certain geographic as well as certain kind of like a population, so we can focus and deploy the intervention to improve. And then we share with the medical group, because it's very important to share the best practice, what work in their peer, and with the provider medical group, so they can deploy those. And if they have seen this, if they improve the medication adherence, improving the hemoglobin A1C control, if they are kind of like being capitated or total care cost of care, they have seen it's also reducing utilization, which means reducing the cost.
Thank you so much. I'll go next to Adrian.
Yeah, I guess, as these are important issues. And so I think this is one of the things that we want to make sure is done in terms of understanding, like, what gaps and how to make sure to close gaps in health equities. And so, again, as things go forward, like being attentive to where we can actually address these things will be important. And I'll just say from a healthcare system perspective, it's in everyone's minds. And it's helpful to have those kind of directions in terms of where we should focus on.
And Brian or Danielle, who would like to go next?
Yeah, I can speak to this. So for the high needs program, there aren't specific metrics for us that are posed at ensuring equity, but the program does allow us to design within our practice our own means of looking in on equity. And one of the ways in which we opted to is to look at the completion of annual wellness visits, which we find are valuable in our population. And we wanted to ensure that our different counties that we serve, we are completing those annual wellness visits equitably, because there are different makeups in the different counties that we serve. So So that's what but the ACO REACH program for high needs allowed us to design our own means. So it's much less burdensome than having the program tell us how we must meet the needs of our population. So I think when designing programs, I just love the fact that our program allowed that flexibility, and I would encourage future models to allow practices to do that. So.
I would probably just reiterate what I'd said earlier about discriminating on a payment basis, whether people have high-speed internet or smartphones or not, and whether visits can be done that way. And then also, you mentioned annual wellness visits. That occurred to me also. There are some payers that don't let you do annual wellness visits via telehealth, or they let you do them, but they don't pay you for them, I guess. And so, that creates barriers for patients that don't have either the ability to get out of the house or to or have technology that lets them have the face-to-face conversation, and that can be frustrating, I guess.
Lee, let's go next to you.
Great presentation. Appreciate the really rich discussion. Dr. Smith, something you said struck me, as I'm sure it did several members of the committee, which is just the nonsensical nature about you having to report to Medicare, or frankly any payer, claims-based measurements that the payer already knows more accurately than you'll ever know it. And I think at some glorious future, we're in a world that metrics, whatever they are driven by the sum total of all population providers and then aggregated. We're obviously in the transitional state that may be the worst of all possible worlds right now, that we're trying to use a fee-for-service mechanism to pay for population-based care, but requiring all the reporting and data to come from the individual physician or practice, as opposed to the population of providers caring for a patient through their journey. So I'd like to unpack that just a little bit. How would you, and I guess ask you to start, but then the whole panel will have thoughts on this. How would you parse through and weigh out the risk benefits of population-based quality metrics based on the sum contribution of all providers to that patient's care journey, meaning that then inevitably some of that's going to be out of your visibility and control, right? You thought the blood pressure measurement was in control, but they saw an urgent care while traveling in Tennessee you didn't know about, and the blood pressure was out of control there, and now it's against you, right? So there's benefits to weigh there. Secondly, as you think about that future time, what shape would you recommend, and who would you think would be best positioned to be the trusted data aggregator and reporter that you would be willing to trust with that?
That's tough questions. So we have our integration with KHI was free to us, and is actually part of our requirement for meaningful use many years ago. And from a population perspective, I think that is, I guess it's weird because we talk about population, but then, I think about the individual patient that I'm putting the information to practice or putting the information to use with. So less of the population as opposed to like gathering the information from, it was aggregated up to, that's a good point, like they're in Florida 6 months out of the year and they get their flu shot down there. And, that's obviously not going to land in KHI's database. But, if they got a LORTAB field in Florida, that's certainly going to land in the Casper database. So I know it's, possible to do these kinds of things. And I have to think from like numerical outcomes like blood pressure, A1C, microalbumins, anything like that. I don't understand why, computers are so good at numbers, why it's not, an average of a number or a trend of the number. And as far as, who to trust, it's I don't know the answer to that because our population is so mobile. If they get a service done in a different state, I don't have access to that information automatically. I don't know what you pick as like the low. I guess what I would do is I start with kind of low hanging fruit. And to me, low hanging fruit are vaccines. And, everybody, the Medicare and Medicaid and, the commercials all pay for, vaccines, and why it's not a or not all vaccines, obviously, but for like flu shots, why that's not required to be reported. I don't understand that. And that's what I guess I would want. I'm not really answering your question because I think you asked a question that will not be answered for the next in my lifetime, at least. Back when I was at Duke in 2020, this is all going to be fixed in 10 years and integrated. And I don't know that it's gotten, feel like it's gotten more siloed and less integrated. Let somebody else solve that problem. Dr. Hernandez, Dr. Whitacre.
Yeah, I actually, over the weekend, I went and bought the easy button. I keep on tapping it. It doesn't work yet. I think one of the challenges is like, for us and for clinicians in practice, like, the easy thing to do is to act on the last patient where you discovered something. That is not convenient for performance measurement, because on performance measurement, we're considering what on average is happening to the population we care for. But I think that data integration issues that you highlight still haven't been fully realized. And so now I have hope. So as things get smarter and smarter, we should be able to do this.
Yeah, and while we don't have the perfect data in front of us, I think allowing us flexibility to figure out with our patient right there in front of us what the most valuable thing to do with them today is. I emphasized in my introduction, and I think I probably sound like a broken record now, but the claims-based performance metrics that we're held to in the ACO REACH program for high needs patients, they make sense. It's what my patient wants. They want me to keep them out of the ER and hospital. They want me to increase their days at home. And how I get there, I get to decide as a provider and work with my patient. And I find areas of opportunity with them together. They don't always have the same agenda as I do, but sometimes what matters most to them is going to be the most valuable thing to address today. We won't get anywhere if I try to address something different. So you take the opportunities where they come with your patients. And I'll get off my soapbox. Flexibility.
I just want to make a comment. I don't know, Dr. Hernandez, like what the color of the button you put, the easy button is the blue button. Like which is the CMS talk about like a blue button to try and integrate all the clinical information. But for us, like because we are the health plan, we are the payer, we collect all those claim and encounter data from the provider. We being the aggregator for the data, and then we provide those aggregators kind of results back to the provider. So they know who has the mammogram done, who has the blood pressures in control or not. And hopefully we get those kind of like a data more timely, so the feedback to the provider is more timely. The other thing I want to comment about the attribution, because it's like, in our situation is a lot of our providers primary care, so they're supposed to be coordinating all the care. So the quality measure is attributed to the primary care provider. But we also have the situation we have kind of like a fee-for-service type of configuration. So the attribution is really depend on how many times the patient's seen that provider. So the more kind of like time the patient's seen the provider, more weight or the measure performance to the provider. So it may not be fair, but that's what the way we did.
And just one other comment about that is that, do you think that those kind of attribution models are feasible? And so then it helps apportion where people are getting the most care and for what kind of care, so that we can direct the measures for that. So.
Yeah, about attribution, I know Danielle, you said you guys have a lot of mid-levels. My understanding is there's some problem with attribution. If they see a mid-level that works for me or works for Danielle 10 times, but then they see an MD one time, they get attributed to that MD as opposed to my practice. I think there's an issue there because it's not always based on tax ID. And as the use of mid-levels, and I don't know if you guys are going to have a different committee on that, but that's only going to grow exponentially. I feel like as, we have a limited number of medical schools, DO schools seem to be expanding. But I think we have the same number of MD graduates, as we did 20 years ago with a population 50 million more. I think there's going to be a bottleneck where we have to figure out that the mid-levels are, in the outpatient world, as an MD, you hate to say this, but as, they're sufficient to be our equals in the outpatient world in a lot of ways.
So yeah, I think there may be challenges in other programs. In the high needs ACO REACH, it's all about plurality, and I don't think that we've seen problems with our NPs or PAs not being able to have the patient attributed to them, even when there's an MD maybe seeing them outside our practice. Our high needs patients they have such difficulty accessing care. We're the only ones seeing them anyway. Our biggest problem is we have them, on average, our patients' life expectancies once they join with us is about 2.5 years. And so it needs to be rapid to get them attributed to us. And sometimes, so sometimes that's our limitation. But it hasn't, because we get our NPs and PAs into the program as participant providers, we're able to get those patients attributed to us. It's just the lag is the problem for us, because when they come to us, they're in dire need and they don't see anybody but us because they can't get out. So that's not the problem, but it's the speed at which they get attributed to us that's important for our practice.
I want to thank each of you for your very valuable insights. It's really informed our perspective today, and the diversity of the perspectives that you come from has been particularly helpful. We want to encourage you to join us for the rest of the day if you're able. At this time, we're going to be going to a short break that will last until 11 a.m. And again, thank you so much for sharing your valuable time and insights. We truly appreciate it. And we'll go to break.
Produced by the U.S. Department of Health and Human Services.